warm welcome to you pharmacology students yet again. So we talked about heart blocks. We've talked about ventricular tachycardias. Now we're going to look at supraventricular arrhythmias. Supraventricular arrhythmias. So to start out, let's give you two different case studies. So we have a young lady. She's a college student. Let's call her Melissa. She's 21 years old. She is at a party, having the time of her life. So she has consumed copious quantities of alcohol, but she has early morning class, so she chases that up with copious quantities of coffee. So we have lots of alcohol consumed, lots of coffee consumed. On her way out, she collapses. However, she wakes up after a couple of seconds. The paramedics are called, and on her way to the ED, she tells the paramedics that she is aware of her heartbeat. Aware of her heartbeat. So again, 21-year-old is at a little social gathering. She drinks a lot of alcohol, chases that with coffee to try and sober up. Then she collapses, wakes up very quickly, tells the paramedic she's aware of her heartbeat. At the ED, she is hooked up to an EKG. And here we have her EKG. Some things to notice. First of all, her QRS complexes are very close together. They're not spread apart. We saw last time when it came to ventricular tachycardias, typically the QRS complex was spread out. Here they're pushed together. Also, we don't really have a good P wave accompanying these QRS complexes. They're also very close together. Her heart is beating very fast. In fact, it's beating at 200 beats per minute. Remember, anything over 100 beats per minute is equal to tachycardia. Now, your next case study is a 32-year-old female and her name is Taylor, and her husband brings her to the ED because she collapsed while cooking dinner. So before she collapsed, she felt dizzy, but now feels fine. And when Taylor is placed on an EKG, her heart is beating a bit more normally, 80 beats per minute. So you can see she doesn't have tachycardia, but her EKG shows something kind of unusual. So the P wave is kind of a blip and then it slurs straight into the QRS complex. So we go this slur, and then we have the QRS complex. We can see that here. We can see it here. Basically, all of these leads here are going to show this slurring into the QRS wave from the P wave. That slurring is called a delta wave. So she has delta waves in the ECG. So let's get back to what these two have after we talk about the different types of supraventricular arrhythmias. So first, let's review the conduction of the electrical signal from the heart. So at the top of the right atrium, oh, can't see that at all, can you? That's a little better. At the top of the right atrium, very close to the inflow orifice for the superior vena cava, you have the sinoatrial node, otherwise as sinus node. Or the SA node. That's the pacemaker. The beat originates at the pacemaker. It is then going to move through the right atrium to the left atrium via these Bachmann bundles. Then it'll move about and back, and then it'll get to the atrioventricular node. From there, it goes through the bundle of His. The bundle of His, there's your AV node there. Goes through the bundle of His, then it splits into the left and the right bundle branches. These will then swing round to the left and the right ventricles around the apex. And they'll then branch multiple times, feeding the different parts of the wall, and these branches are called your Purkinje fibers. Once the signal essentially gets here, it reaches tissue that's already depolarized and is in its refractory state, and so the conduction has occurred, and then, well, also there's a fibrous skeleton here. Let's maybe put in our fibrous skeleton. And that fibrous skeleton is going to prevent the beat that swings, the electrical current that swings around here from going up to the top of the heart. All right, so that's the review of the electrical system of the heart. Now, when we talk about an arrhythmia, we need to know what a normal ECG looks like. So a normal ECG is going to have a proper P wave. That's the wave that indicates atrial depolarization, followed by a QRS complex. That complex indicates ventricular depolarization, followed by a T wave. And the T wave indicates ventricular repolarization. The P wave is followed by the QRS complex, which is followed by the T wave, and then the T wave is followed by yet another P wave. You then have different intervals. And as you can see those here, you have a PR interval that's measured from the beginning of the P wave to the beginning of the QRS complex. So this PR interval typically is no more than 200 milliseconds. You then have the QT interval, which we talked about last time. That starts at the beginning of the QRS complex to the end of the T wave. The PR interval, remember, that's the time it takes for ventricular filling. QRS complex indicates contraction of the ventricles because that's the time during which the ventricles are depolarizing. T wave, that will be a time of ventricular relaxation. Very good. So when we talk about a arrhythmia, as we said before, an arrhythmia refers to a disruption An arrhythmia is a disruption in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity. Any disruption in the rate, rhythm, site of origin, or conduction of the cardiac electrical activity, that is the textbook definition of a cardiac arrhythmia. All right, now if your arrhythmia originates from the ventricles, so you have an arrhythmia that is a result of some sort of abnormality in the ventricles, that's going to result in a so-called ventricular arrhythmia. If, however, your arrhythmia originates in the atria, so essentially from the SA node to the bundle of His, now it's going to be called a supraventricular arrhythmia. Supraventricular arrhythmia. And that's what I'd like to talk about today. So the first type of supraventricular arrhythmia originates essentially in the SA node. So these are of so-called sinus origin. Sinus origin. So the first of these is sinus tachycardia. So you have a heart rate that is greater than 100 beats per minute, but you have a regular rhythm. So this can be physiological or pathological. If it's physiological, which happens during exercise, or it can be pathological. Physiological or pathological. All right, so the pathological sinus tachycardia typically occurs when the heart needs to compensate for an acute decrease in stroke volume. If you don't remember what stroke volume is, I will let you look that up. So if you have an acute decrease in stroke volume, you will have a compensatory sinus tachycardia. What sort of things would cause an acute decrease in stroke volume? Things like acute heart failure, can cause such a thing. So can an acute myocardial infarction. Also, so can a pulmonary embolism. So in the case of a pulmonary embolism, you have a clot that formed usually someplace else in the body. It detaches, it then sojourns through the bloodstream, and it gets trapped in the pulmonary capillary system that surrounds the alveoli. A pulmonary embolism is a medical emergency, and that can decrease stroke volume. So compensation would be sinus tachycardia. That's why during surgery, you want to watch the heart monitor rather carefully. If you start to see the heart rate go up to tachycardic levels, a potential clot is a possibility. Another cause of sinus tachycardia might be overwhelming activation of the sympathetic nervous system. Now, yes, this might be due to the fact that you're terribly scared. So fear or panic can do this. However, there are other means by which you can hyperactivate the sympathetic nervous system. Hyperthyroidism can also cause sinus tachycardia. So can cocaine or amphetamine use. Now, what's the problem with the heart beating so fast? The problem with the heart beating so fast is that it decreases your diastolic filling time. That goes down. That means as the heart beats faster, heart rate goes up, your stroke volume actually goes down because you're just not filling the heart. So over time, your heart has to make more catecholamines. These catecholamines include things like epinephrine and norepinephrine. Over time, large quantities of these catecholamines can be toxic to the cardiomyocytes. So this constant tachycardia can cause tachycardia, induced cardiomyopathy. Which gets abbreviated TIC. And for this reason, you want to take the means to slow the heart rate down if you have this constant tachycardia. And people who abuse cocaine or amphetamines, crystal meth, things like that, you run the risk essentially of doing your heart in via this tachycardia-induced cardiomyopathy. So that's sinus tachycardia. That is a arrhythmia of sinus origin. Now, a second type of arrhythmia, also of sinus origin, is sinus bradycardia. So in this case, the heart rate is going to be lower than 60 beats per minute. And this, of course, can be completely physiological. Physiological in athletes, I'm sure if we took the heart rate, say, of, Remington, I'm sure his heart rate would be well below 60 at rest. Now, bradycardia can also occur normally during sleep. So in those cases, bradycardia is normal. There can be pathological causes of sinus bradycardia as well. So for example, hypothyroidism, that can cause sinus bradycardia, as can anorexia nervosa, and so can inferior wall myocardial infarctions. Those can cause sinus bradycardia as well. Now there's another cause of sinus bradycardia that is part of the so-called Cushing reflex. The Cushing reflex. This is a triad of bradycardia, hypertension, and an irregular respiratory pattern. This is a consequence of increased intracranial pressure. And this can manifest from, it can be a manifestation of pathologies that result from head trauma, strokes, and also brain tumors. So if someone's been someone's been in a car accident and they have a low heart rate but also hypertension, and you start getting a respiratory pattern that's irregular, this is a pretty safe bet. There are ways to measure the intracranial pressure, but they're usually invasive. But if you see this Cushing's reflex with this triad, you usually want to measure that, because if this cranial pressure continues to increase, you are at high risk for brain herniation. Brain herniation, and that is a medical emergency, to say the least. There are also medications that can cause sinus bradycardia. So beta blockers, certain types of calcium channel blockers, and then also opiates can also cause sinus bradycardia. So acute sinus bradycardia is treated with intravenous atropine, and severe cases may need a pacemaker. That is sinus bradycardia. Then you finally have sinus arrhythmia. This occurs naturally during inspiration and expiration. If you don't believe me, all you need to do is to get a nice either radial pulse or get a jugular pulse, and then take some breaths. As you inhale and exhale, pay attention to the heart rate. You'll discover that the heart rate will change. During inspiration, your heart rate will increase. During expiration, your heart rate will decrease. Now, there may also be cases, however, that are not normal, where the sinus node will simply fail to fire. So on an EKG, you get a so-called flat line pause. A flat line pause. And if the sinus node can't press that reset button, then typically the AV node or any other myocardial cell might take over. In a case like that, until the SA node just gets its act together. So on an ECG, you will have a irregular rhythm. That irregular rhythm may be just it speeds up, slows down, speeds up, slows down, or that you may have sinus arrest or sinus exit block where the node fails to fire. Both of those constitute so-called sinus arrhythmia. Some people have this, it's completely asymptomatic, and unless it becomes really severe, you don't usually need to treat it. If you do need to treat it, usually you treat it with a pacemaker. Now, if your arrhythmia is not due to the sinus node, then you have something that is typically called a reentrant arrhythmia. A reentrant arrhythmia. So in this case, the electrical activity gets trapped in a circular racetrack. So the electrical activity is trapped in a circular racetrack. Let's give you a little example of this. So here, for example, we have a normal situation where a signal, electrical signal, comes from a higher place in the heart. It then will go this direction and this direction. These will then split, come around this way. They'll meet here. These two signals to beat will then go this direction like this. That's your normal situation, and you see there is a normal action potential. However, if you have some sort of anatomical or structural abnormality because of cell death, because of a developmental condition, whatever the case might be. Now, this signal can't go this direction because of some sort of blockage. The signal therefore splits this way. It goes over here and over here, and then it will come up this direction as well. And if it makes its way around, essentially, this blocked area, because this is 3D, remember, it can then cause tissue over here to actually start to repolarize. Instead of the beat coming from this direction, it comes from this direction here. That will tend to cause a arrhythmia that will cause usually a type of tachycardia. So that's an example of a reentrant type of arrhythmia. So and you can imagine essentially an area like this being damaged by a myocardial infarction. So there's three types of these reentrant arrhythmias. There is, first of all, so-called paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. Paroxysmal supraventricular tachycardia. The other is atrial flutter. And the third is atrial fibrillation. Let's start with our paroxysmal supraventricular tachycardia. So in this case, you have a reentrant circuit that loops within the AV node. So essentially go SA to AV node and then back again. So this is sometimes called AV nodal reentrant tachycardia. This can happen in people with completely normal hearts and no history of cardiac disease. This can occur because of recent consumption of things like alcohol and or caffeine. In the form of coffee. Or it could be caffeine pills, if you have students who take caffeine pills. In my day, there was this stuff called no-dose you could take. It was just caffeine pills. And if you take a lot of those, you tend to get Some of that going on. So what do you see on an ECG with a person with PSTV? You see these QRS complexes that are very narrow. You have an absence of normal P waves. Absence of normal P waves. That tells us the SA node is no longer in control. So the reentrant circuit is within the AV node, meaning it can go from the AV node up towards the atria. Since it's going in the opposite direction, you may see retrograde P waves. Because the paroxysmal supraventricular tachycardia is extremely fast, these retrograde P waves are usually buried within the QRS complex. So you usually don't see them. You may see them. You usually don't. So the heart rate is very high. It's 150 to 200 beats per minute with paroxysmal supraventricular tachycardia. These, fortunately, can be treated with so-called vagal maneuvers. Where you massage the carotid sinus. When you do that, the vagus nerve activity increases, and now the heart rate will decrease. They used to teach EMTs this maneuver. They don't anymore. However, your ED physicians will tend to know how to do this. And if this doesn't work, then you use adenosine. Adenosine is given intravenously. It acts in about 15 seconds. Adenosine causes a decrease in AV node conduction. Adenosine can be blunted by drugs like theophylline and caffeine. Side effects, essentially, of PSVT are side effects, essentially, of adenosine. Adverse effects will be facial flushing, hypotension, that means low blood pressure, bronchospasm, and then chest pain. And that is paroxysmal supraventricular tachycardia. Now we move on to atrial flutter. Atrial flutter is essentially caused by a reentrant circuit that runs around the annulus of the tricuspid valve on the right side. So essentially the circuit is going to go from here and it's going to swing around here just like that. So around and around and around and around and around we go. All around the annulus of that tricuspid valve, all the way around like that. That's going to cause atrial flutter. Atrial flutter. And here's another picture showing you essentially how it goes just around like that, around the annulus of the tricuspid valve. Now with atrial flutter, the heart rate is very high. It's 250 to 350 beats per minute. Really high. Because of this way fast heart rate, some of the signals to beat get down through the AV node to the ventricles, some of them don't. So because some impulses get through, and some don't, you're going to get a so-called atrial ventricular conduction ratio. Usually, 2 of the atrial beats will result in 1 beat in the ventricle. And if that's the case, if the atrial heart rate, say, is 300, then the ventricular rate, say, will be 150. In other cases, it could be 3 to 1 or even 4 to 1. And on the EKG, you're going to see so-called flutter waves. Flutter waves. And so the P waves are going to give off a so-called sawtooth appearance. Let me show you one of these EKGs. You'll see what I mean. So here is your QRS complex. This one didn't get through. There's an atrial contraction. There's one, there's one, there's one. That gets through. There's one, there's one, there's one. That gets through. See the sawtooth appearance here that is very characteristic of atrial flutter. All right, so typically you need to do electrical cardioversion. In order to keep atrial flutter under control. And that's typically done with catheter ablation. All right, that's atrial flutter. Finally, we have, risk factors for atrial flutter include hypertension, and coronary artery disease, CAD. Those are your main risk factors for developing atrial flutter. Now, finally, we get to atrial fibrillation. In the case of paroxysmal supraventricular tachycardia, we had essentially one part of the heart that was responsible for the reentry. In the case of atrial flutter, there was a single reentrant circuit that caused a problem. In atrial fibrillation, you have multiple, even hundreds, of reentrant circuits that cause a problem. Common risk factors are going to be hypertension and coronary artery disease. Another cause of atrial fibrillation can be holiday heart syndrome. This is a bit of a, well, it's no laughing matter, but it's a bit of a joke around the ED with the cardiac people, because this can be caused by binge drinking. Now, what do you see on the ECG? Because the atria are just quivering, they're not beating in a coordinated fashion, there are no P waves. Remember that. No P waves. So if we look essentially at an EKG like this, here's your QRS, here's your T, then you basically get this other rubbish here. QRST, rubbish, 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 QRST, rubbish, rubbish, rubbish. And notice that the rubbish doesn't match any pattern. It's just different every time. There's no discernible T wave amidst the rubbish. Yeah, you could say that might be a P wave, but it's not at all reproducible. It's just part of the rubbish. Heart rate's quite fast. The heart rate in this case can be greater than 500 beats per minute. The poor AV node is seriously overwhelmed, so we don't get AV conduction ratios. The AV node allows the passage of impulses essentially in a random and unpredictable fashion. So again, the atrial muscles are shaking uncontrollably. There's no actual atrial contraction. Your ventricular rate in this case will usually range between 120 to 180 beats per minute. Now, since atrial contraction only contributes some 10 to 20% of the cardiac output, people can survive with this. However, in people with a weak heart, that 20% might be really crucial. The big risk with atrial fibrillation is the pooling of blood in the atrial appendage. The atrial appendage is in the left atrium. When you get pulling of blood like that, you're at risk for a clot. That clot can dislodge. It can travel into the systemic circulation. It can cause multiple life-threatening pathologies like embolic strokes, limb ischemia, central retinal artery occlusion, acute mesenteric ischemia, of course, myocardial infarction. So you treat atrial fibrillation usually with beta blockers or with cardiospecific calcium channel blockers. Some individuals can be treated with cardioversion. All right, so your third type of supraventricular arrhythmia would be those in which the electrical activity originates from some place other than the sinus node. So these third types, the origin of electrical activity somewhere other than the SA node. So one type of this particular type of supraventricular tachycardia, supraventricular arrhythmia, is so-called multifocal atrial tachycardia, or MAT. In this case, you have multiple ectopic foci firing from the atrium. This is classically associated with chronic obstructive pulmonary disease or asthma. This is kind of a high yield fact I'd really like you guys to be aware of. Multifocal atrial tachycardia is typically associated with people with chronic asthma or chronic obstructive pulmonary disease. Now, in this particular condition, this is small, I know, but you have P waves. So P waves are present. However, you have an irregular rhythm That irregular rhythm is also very fast, so your rate is up 100 to 200 beats per minute. Also, your P waves show multiple different morphologies. And typically for MAT to be diagnosed on an EKG, you have to have at least 3 different P wave shapes. At least 3 different P wave shapes. So you have P waves, they vary in shape. In order to diagnose MAT, multifocal atrial tachycardia, those P waves have to have 3 different shapes consistently. And this is associated with people with chronic asthma or chronic obstructive pulmonary disease. Okay, finally, let's talk about pre-excitation syndromes. Pre-excitation syndromes. In this case, there's some sort of accessory pathway. And this accessory pathway acts as a shortcut to the normal electrical circuit. And this causes the ventricles to be excited earlier than usual. There are several of these, but the one that is important for our purposes is called Wolff-Parkinson-White syndrome. This gets mercifully abbreviated to WPW syndrome. Now, in Wolff-Parkinson-White syndrome, you have an additional bundle, and it can be in lots of different places. I'm just going to stick it over here. That's called the bundle of Kent. The bundle of Kent. And this bundle of Kent essentially is going to cause your circuit, as it comes from here to here, to go right straight back here again. So because you have this extra pathway, you can go straight from the ventricles here. You don't have to wait for the AV node. It'll go here, or after it finishes beating, it can go right back to this area here, essentially. The cause of Wolff-Parkinson-White syndrome is typically not known, but you do see it in an autosomal dominant mutation. In the PRKAG2 gene, and this is a gene that encodes a protein that regulates ion channels. It regulates ion channels specific to cardiac tissue. What do you see in the EKG? You see delta waves. And so with these delta waves, you have a shortening of the PR interval. You will also have a widening of the QRS complex. The delta wave essentially will indicate that your ventricle is activated earlier than it normally should. And this essentially is what the EKG will look like. You have the slurring essentially of the PR interval from the P wave interval slurring straight in to the QRS complex. You have a shortening of the PR complex, presence also of the delta wave, and a relative widening essentially of the QRS complex. So if we were to get back essentially to our case studies that we had at the beginning. So Melissa, she's had a great time plying herself with alcohol and coffee. She has a very fast heart rate, and her EKG showed very narrow QRS complexes with no P wave. The alcohol and coffee, she essentially has paroxysmal supraventricular tachycardia. And a cardiac sinus massage will return this back to normal, and then she can be sent home. What about the case of Taylor? And with Taylor has delta waves. So she has Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome is very treatable with certain types of cardiac drugs. One of the drugs, in fact, that's quite good for it is a 1A, class 1A antiarrhythmic called procainamide. And that is a drug that can be used very successfully. Okay, I hope you survived that onslaught. Those are the supraventricular arrhythmias.